as soon as it connects. It doesn't give a good countdown. So, all right. We are trying out a new thing today. So just thank you for your patience where we are. Okay, cool. We are going through Zoom, through Restream, and then to LinkedIn and YouTube Live. So we are getting very fancy. But it looks like everything is happening. Um, so okay. Welcome to Healing Horizons. And each week we share the latest news and research in trauma-informed care, positive and adverse childhood experiences, and psychological safety. I'm Alison Cebulla.
And I am Twombly. And we are both at 10 Collective, where we are really trying to create a world where we genuinely care for one another, where those relationships are genuine, we care, we respect for the other person. And we really want you to consider hiring us here to help kind of walk along with you on your journey implementing trauma-informed care as well as psychological safety within kind of your programming, within your policies, your procedures, your hiring, onboarding, just thinking about all the different ways that you care for your employees, as well as the different communities and families that you're serving and partnering with.
Yes. So you can hire us. So feel free to reach out, send us a message, visit our website, tend-collective.com. So let's get into the news. Today is Thursday, April 18th, 2024. We will be addressing things that involve trauma and sometimes violence. So the first piece in trauma-informed care, and by the way, we really like highlighting different interventions related to these topics to help people who are tuning into this segment to see different interventions that you could maybe think about implementing. We also offer commentary on maybe like what we might want to do differently, given our expertise in designing and evaluating interventions that are trauma-informed or address adverse childhood experiences or toxic stress. So we really like highlighting these interventions. And let's get into it. So the first one is a innovative program focuses on homeless trauma. The VA Boston Homeless Programs offers a trauma-informed care approach. By the way, you can go to our website after this live stream to get a list of the articles that we are referencing. So this is a unique program at Boston VA. And I want to clarify because I'm like, there's so many acronyms, you can't just assume that everyone knows what VA stands for. Veterans Affairs. And so at Boston, Veterans Affairs is using the foundation of trauma-informed care to better assist veterans experiencing homelessness. Spearheaded by Karen Guthrie, co-coordinator and supervisor of CATCH, which stands for Care Coordination, Advocacy, Treatment, and Connections to Housing. These acronyms. The program hired staff who shared trauma-informed care values and were committed to learning and practicing the model. And they work together as a team to develop a mission and to apply the SAMHSA, which stands for Substance Abuse and Mental Health Services Administration, trauma-informed care principles. And we've talked about these principles a lot. This is the foundation of a lot of trauma-informed care. And these are safety, trust and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So this program is utilizing these principles to help team members look past symptoms of trauma, labels, and diagnoses, to explore why people are behaving in the way that they do, and making sure that they're empowering the people that they serve and not re-traumatizing them. And so, yeah, I guess I would be curious to hear other specifics, but it's always nice to know that programs that are serving really vulnerable populations are taking the time to really understand the trauma-informed principles. I think that's such a great first step, is to just train the whole staff to know. Now, of course, ideally, we would want to go upstream and think about, well, how can we prevent homelessness? Or, why are veterans such a vulnerable population with a propensity for experiencing homelessness? That's, we really like to see upstream solutions, but you can't have any upstream solutions if your staff doesn't even know what trauma-informed care is. So, it sounds like they got this really passionate person who is dedicated to integrating trauma-informed care at every level. They've been training the staff. They're looking at not re-traumatizing the people they serve. So this is such a great start. What was interesting to me is the fact that the field of trauma science comes out of research on veterans. So the entire field is based on veterans experiencing post-traumatic stress disorder, shell shock, and coming into the doctor's office, having these symptoms noticed, and over time the PTSD diagnosis was created. I believe that The Body Keeps the Score tells like a really nice, succinct history of how this came to be a diagnosis. Bessel van der Kolk's book, highly recommend. But it's just interesting to see this being labeled as innovative, whereas those of us in the field know that actually, rather than being innovative, the entire field comes out of veteran care. So, trauma-informed care really should be standard for anyone involved in military combat. And I often see that it is. I often do see trauma-informed care initiative happening at VA hospitals and psychiatric centers. We hear about that a lot. But good to know that this is happening in Boston. Any comments, Bree?
Um, I think one of the other things that was powerful about this is that they were really trying to move away from kind of labeling or categorizing people,
Yeah,
which can be re-traumatizing.
right.
Because it takes away power, and right, like one experience or one part of us maybe, or our like current experience doesn't define who we are. Being unhoused may not be how we define ourselves. And to go in and say, here's the box that we're in, like that's the box we have to check, that may not be who I am, and that doesn't give me the power in the situation. So I really liked kind of the commentary that the article had around that as well.
Yeah, great. Okay, the next trauma-informed care program that we're highlighting is Canada's top fertility specialists introduced groundbreaking trauma-informed fertility care program. So this was an article that came out March 19th, 2024. And so Trio Fertility, renowned as a Canadian leader in advanced fertility treatment, proudly announces the launch of its innovative trauma-informed fertility care program. This program revolutionizes fertility care by integrating a compassionate and personalized approach to address the emotional complexities of trauma. Trauma, with its profound and lasting impact on individuals, necessitates specialized attention in fertility care. TRIO's program is dedicated to prioritizing a supportive environment that understands, acknowledges, and responds to the aspects of the fertility journey that may trigger past traumatic experiences of patients. And one of the people from that clinic says, we understand the importance of providing holistic care that addresses not only the physical aspects of fertility, but also the emotional well-being of our patients. So this was something that I saw that I thought, you know what, that's perfect. That is the essence of what trauma-informed care is supposed to do. So, sometimes we report on these interventions and we go, that's an interesting take on trauma-informed care. I wonder how they made that translation. But this is really the heart, and it really can be this simple of just again, you know, understanding, acknowledging, and responding to the fact that past traumatic experiences may be triggered when it comes to fertility issues is, and applying it to the specific sector is exactly what trauma-informed care should do, quite simply. Just understanding that people may have past wounds, traumas, things that get triggered, understanding what's happening in the brain and body, understanding the types of situations and events that may trigger something like this, and just being like, hey, we totally get it. And we're going to respond in a way that acknowledges that this is real and exists. So this is a simple one, and it's really just perfect to just hold space for the whole breadth of emotional experiences. So yeah, sounds like a great way to offer care.
Yeah, I really love that one too, just holding all of that in mind. And I think when you're the kind of professional within that setting sometimes, and you're seeing the same things or hearing the same things, like we can kind of become like maybe like numb to that like trauma. Like it's just that is what happens. And so to really continue to like be present and to honor that space and stay in a space of like this is this person's experience, and it actually is traumatic, just because we are seeing and it seems very common to us, and maybe we've become numb or taken our
Mhm.
own to protect ourselves in that work.
Yeah.
um yeah, being able to kind of honor that space and create um those healing and supportive spaces, it's really
Yeah.
awesome.
Yeah.
Um, there is also a new trauma recovery center, which this is something that I want to just look into and learn more about these. Because in reading this article about this one that's opening in Brooklyn, there are ones in various different locations across the United States. And so I really want to learn more about them, the different models that they use, and lots of things. But we just wanted to highlight one that is just recently opened in Brooklyn. And trauma recovery centers are really designed to reach survivors of violent crime, who have less access to traditional victim services, and that are also less likely to engage in mainstream mental health or social services. And there can be many reasons why there can be those barriers in place to kind of engaging. One of the things that I really like is they provide wraparound services, and they help to coordinate care. So for things like mental health, physical health, legal services, they bring together a multidisciplinary team to be able to support. And I love that there's that wraparound is thinking about what are all of the different services, who are all of the different people that
Hmm.
a victim may interact with, and how can we help to reduce those barriers to accessing them, reduce those kind of communication barriers and those interaction barriers between people, and really creating that kind of wraparound team or community for that. So I
That's
really,
what we like to see.
yes. When I saw the word wraparound and read more about it, I was like, yes, yes, yes. And so they really can help to stop cycles of violence. So things like gun violence, domestic violence, sexual assault, human trafficking, as well as hate crimes. And like I said, I learned that they've actually been around since 2001. At the University of California, San Francisco. That's where they kind of first started. And because they've been around since 2001, there's actual research out there that's showing how they can be really effective. So they improve public safety because they help to interrupt cycles of violence,
Hmm.
and to increase participation in the legal process. They've also been shown to reduce symptoms of PTSD and depression. They have increased the rate of attending follow up services for sexual assault survivors. And just from a financial standpoint, it costs around like 34% less than typical kind of fee for service care. So lots of benefits from these trauma resource centers that we've been kind of seeing already. And they're really, again, just trying to remove those barriers to care, so people, and especially people of color, can access culturally competent, trauma informed, evidence based mental health care. And so, one of the things that I'm curious about and want to learn more about is when they're talking about kind of evidence based care and the models that they're using, what are those? Because evidence based has that evidence behind it of it works, and it's important to look at and ask critical questions like who were the participants in the study, who were the researchers, especially thinking about race and gender. What
Mhm.
does actually generalizable to the entire population, and thinking that there are a lot of cultural healing practices that may not be evidence based, because
Yeah.
they're not just by white people. They don't receive funding to kind of make them evidence based. So, are those being considered and utilized as well? So, I'm really curious about that. And it's just some homework, I guess, that I have for myself to learn more
We
about
know
this.
how tricky that is, though, about because, then working at a place that doesn't that that there can be places that just absolutely make up interventions that are not culturally based and not evidence based, like they're just, and so evidence based is like supposed to ensure that someone has decided this is a good idea, but then of course then there's so many limitations with evidence based because which populations are excluded when we've studied and decided what works well, and who's excluded from being studied, who's excluded from being the researcher, and then of course all the different biases. So it's it's so tricky, but then it's like a lot of harm can be done out there when things are not evidence based.
Mhm. Yeah, it's a really interesting thing that I know there are continuing to be more conversations around, how our populations determined for research studies, who are the researchers, how are we kind of thinking about and addressing potential like bias or harm from the beginning of research studies. And it's a really important thing that needs to happen that hasn't happened in a lot of prior research. So having that critical lens, looking at evidence-based, is really important, as well as if you're thinking about interventions, are you talking to the families? Are you talking to the people that are coming in? How is their voice being centered when
Mhm.
talking about interventions, when you're choosing interventions? When we're doing programming, we should never be making decisions without the families voice being centered within that. So, um,
Absolutely.
yeah, holding that in mind too. Um, I want to then highlight two different kind of peer-reviewed studies that have been put out kind of within the last 2 months related to ACEs. And I'm excited about both of these studies. They kind of just reinforce things that has already been shown in the research. But by reinforcing, it really gives us that like, okay, here's the things for us to do to try to be preventative, to try to have those
Yeah.
interventions that can be really supportive. So one is a study out of the University of Michigan, and that has shown that traumatic experiences during childhood may literally get under our skin later in life, because it can end up impairing the muscle function of people as they age. So this study was published in the March 2024 edition of Science Advances. And they used data from the study of muscle, mobility, and aging. And that had 879 participants. 59% were women. The mean age was 76.3 years, and 86% self-reported as white. So again, when we're looking at these studies, who participated in this study? So
Right.
this had higher female. It was predominantly white study. So important things to kind of hold in mind and look at critically as we're kind of looking through
Mhm,
the
mhm.
so the study really examined the function of skeletal muscle of older adults, and then they paired that with surveys of adverse events that they had experienced in childhood. The study didn't use all of the adverse childhood experience or ACEs questionnaire. They kind of used 6 questions from that, which I thought was interesting, and I'm really curious kind of about that. They also didn't include anything that kind of wasn't through kind of like interpersonal trauma. So thinking about like community violence or racism, those weren't looked at as kind of adverse experiences within that. So again, just being kind of curious about which ones were chosen, which ones were excluded for this study. And what they found is that people who experience greater childhood adversity, so reporting one or more adverse events, had poorer muscle metabolism later in life. So this is really critical because it means that the mitochondrial functioning, this is technical as I'm going to get in this one, has which can end up leading to different chronic conditions as well as disability limitations across the lifespan. So it's really changing what's going on within kind of the mitochondrial functioning within the body. And so I thought this was really interesting because it's just showing another way that trauma can actually alter and change what's going on within our bodies. Um, for me, it's really saying like, how are interventions supporting healing within our brains and our bodies? Not
Yeah.
just
Yeah.
talking, but like, what are we doing to repair our stress response system? And again, there's things that we can do on an individual level or in partnership with others to help us to support kind of healing our stress response system. And then also thinking about what are those systems? What are those policies that are in place that are contributing to that stress? And how are we changing those, again, to promote healing instead of causing trauma or kind of activating people's kind of trauma response systems again. And then the last study that I want to share today is out of Australia, and it was looking at how much do adverse childhood experiences contribute to adolescent anxiety and depressive symptoms. So this was just published this month in the BMC Psychiatric Journal, and it really had two goals, the study, to examine the association between ACEs and elevated anxiety and depressive symptoms in adolescents, and then to estimate the burden of anxiety and depressive symptoms that are attributable to ACEs.
Whew.
Sometimes is I feel like when I'm doing my ACE interface and I'm talking about epidemiology and epidemiologists, then just get
Yes.
sometimes.
Yes.
Uh, so in this study, they had 3,089 children, again in Australia, who they followed between what they called waves one, which the children were ages 4 to 5 during that time, and then wave seven, which children were 16 to 17 during that. And this was part of the longitudinal study of Australian children. And 51% of respondents identified as male. I couldn't, within the study, find any kind of racial or ethnic breakdown of participants. But what they found in their study is that before the age of 18, 68.8% of the children had experienced two or more ACEs. And it found that both history, as so kind of historical exposure, as well as current exposure to bullying, victimization, and parental psychological distress were associated with a statistically significant increased likelihood of elevated anxiety and depressive symptoms at ages 16 to 17. Overall, they found that 47% of anxiety symptoms and 21% of depressive symptoms were attributable to a history of bullying victimization, and 17% of anxiety and 50% of depressive symptoms at ages 16 to 17 were related to parental psychological distress experienced between the ages of 4 and 15. So these findings are really kind of demonstrating that interventions to reduce exposure to ACEs, especially the parental psychological distress and bullying victimization, can help to reduce anxiety and depressive symptoms in adolescents.
I
Um,
yeah, I wanted to say, when those of us who work in this field often come here for personal reasons, whether we were impacted by trauma or had someone close to us who maybe struggled with a severe mental illness. What we come to find out on our healing journeys and through reading, some of the really wonderful literature out there, such as that by Bessel van der Kolk or Gabor Mate or Bruce Perry, um, is that it's often not the thing itself, like say in this example, the bullying, but it is that lack of attunement by the parent. So it's the parent missing the fact that their child is in distress. So let's say, and I'm not exactly sure by what context they were looking at bullying, but let's say a child goes to school and experiences bullying at school. Then they come home and they're really distressed. But as the study says, their parent also has some psychological distress going on. They don't even notice what's happening for the child. That's the trauma. It doesn't Gabor Mate have a thing where he says it's not the trauma, it's the lack of what is the quote? But it's not what happens to you, but it's what
I
dang
can't
it.
remember what it is.
I'm recovering from a cold, and so it's just things are not firing at the speed. But oh, it's what happens within the absence of an empathetic witness.
Yes.
Woo, we got there. The absence of the empathetic witness is, I think, the key part here because, humans are so resilient and strong, and but we need someone to notice how we're doing as children, and of course as adults as well. But someone needs to care how we're doing. And so if that is missing, that is going to be, based on what I have come to know and understand about trauma, the thing that really solidifies some of the long lasting negative impacts.
Yeah, and I think to your point, Alison, there's been research over the last few years related to positive childhood experiences and protective factors. And a big one of those is relationships and the power of having relationships with caring, safe, stable, um, kind of adults within the child's life. So, right, that adult that can be attuned to them, that adult that is asking them questions, that is helping them to feel special, to feel valued, to feel cared for. Um, and we want that to be happening at that relational level. And then again, I think there's the systemic things to think about. What is happening within kind of our communities, our environments, that makes it so a parent maybe can't parent in the way that they would like to, or can't be as present as they would like to, because they're trying to earn enough money to be able to pay their bills.
Yeah. Yeah.
Because of the hours that they work, they can't access mental health care. There's so many systemic barriers there. And what would happen
Yeah.
if all people were earning a living wage? They didn't have to worry about that financial stress. Would they then be able to be more present and be the parent that they wanted to be with their child, to have kind of that bond, and to really strengthen that kind of protective factor for their child. So I think there's that individual relationship piece, and then also that systemic piece that we have to look at of how do we change systems so we can be preventative rather than continuing to having to provide intervention and treatment to people because things are always happening.
100%. And then I just want to respond to Carrie. Thank you so much for following along and offering comments on LinkedIn. We kind of can't respond in the chat based on the platforms that we're using. I hope we figure that out at some point. But just validating the kind of the neglect piece being so harmful. So thank you. So psychological safety. Yeah, I have a little bit of a doozy that I want to address. When it comes to employee psychological safety, I think that we have all been watching the Boeing whistleblower case happening before Congress. And I know that a lot of us, myself included, have been really distressed about the original whistleblower, John Barnett, who was going to testify in this case and then was found dead in his car a few weeks ago at age 62 with, what seemed to be a self-inflicted wound. So there is a new whistleblower testifying in his place, Sam Salapore, a quality engineer for the company. And he told the U.S. Senate subcommittee that his boss threatened him after he voiced his concerns about various Boeing protocols going awry. Quote, my boss said, okay, and Carrie puts in the chat, suicide? I think not. Yeah, then that's why this is a super scary case that I would love to hear us all continue to talk about as we work together to create psychologically safe work environments, because this has an impact on all of our mental health when we see things like this happen. And there's questions about whether someone is, their life may be in danger if they bring up whistleblower concerns. So Sam Salaport said, my boss said I would have killed someone who said what you said in the meeting. This is not safety culture when you get threatened by bringing issues of safety concerns. And so what we've covered in a past webinar about coercive control in the workplace is that oftentimes threats are made at work, even if they're not overt, they can be covert threats. And the implicit threat being, if you don't do X, Y, and Z, or if you bring up X, Y, and Z, your job and your livelihood is at risk. And that tends to be the underlying piece to coercive control in the workplace that makes it so psychologically unsafe, is that people are afraid they will lose their job if they either speak up or don't do exactly what they're told, even if that violates their moral beliefs. So watching this case and hearing that, these types of even though it wasn't a direct threat, but saying, I would have killed someone who said what you said in the meeting. This is, of course, this is a really scary thing to hear. And the thing about the Boeing planes is that these are having real consequences for users of Boeing flights. So, most notably, the door plug fell off the Alaska Airline Boeing 737 MAX aircraft at an altitude of 16,000 feet in January. We all saw that. And then we've continued to see various accidents happen since then. We've been watching with horror. So this is having a real safety impact on a large population of people in the United States or anyone flying in a Boeing aircraft. A preliminary investigation revealed that that door that popped off was missing 4 bolts. And that we've come to find out there just hasn't been a culture where employees felt safe to say, hey, I think we need to slow down and think about this. So, yeah, let's keep following this. I hope that this whistleblower continues to be safe to speak out. And of course, we know that CEO of Boeing has stepped down. And so hopefully they can turn this around and create a psychologically safe culture. And hopefully, because we're all watching, this can be a great example of holding a company accountable so that we all can feel empowered to create psychologically safe work cultures wherever we work. That one is, yeah, that's, such a big story right now in psychological safety. And it's a lot to take in. Yeah. So lastly, this is our last piece for today on psychological safety. And this one's from the journal Healthcare from April 2024. And again, all of these links will be on our website for this episode. So, if you want to follow up and read any of this stuff on your own, go to our website. We'll typically have it up within 24 hours. So this one is speaking up and taking action, psychological safety and joint problem solving orientation in safety improvement. And this one is so jargony. I think this is the one that is, Harvard Business School and Harvard Chan School of Public Health is where this came out of. And I shake my fist at how jargony this piece is, because I just don't think it needs to be, it could be written in a way that's a little more friendly to the lay person, but let's try and get through it. So healthcare organizations face stubborn challenges in ensuring patient safety and mitigating clinician turnover. This paper aims to advance theory and research on patient safety by elucidating how the role of psychological safety in patient safety can be enhanced with joint problem-solving orientation. So I was like, what the heck is joint problem-solving orientation? And this is actually something, I worked as a one-on-one health coach for a number of years, 5, 6 years. And we would often say in the coaching world that a person is going to have more self-efficacy, want to tackle the problem if they come up with a solution on their own. So joint problem-solving orientation seems to be just that. If you are working together with your patient to come up with a solution, they are going to be more likely to implement it, as opposed to a top-down authoritarian style approach to health solutions. So that seems to be, from my understanding, what this article is saying. So I'll go on to share that studies in other high pressure environments have shown that improvement efforts tend to be centralized and hierarchical rather than collective and democratic. This can be an efficient approach to improvement, right? Obviously, just telling everybody what to do. You don't have to decide and discuss and agree as much, so it could save time. Sometimes that might be the right approach. However, our measure of psychological safety also points to risks in this approach, specifically across the items comprising psychological safety. So what they're saying is that patients may actually feel more safe and comfortable having that joint solution being a part of their own care. So, and this, this really does go in line with things that we have done webinars on, which is that authoritarian style or hierarchical style interventions in which you have someone at the top telling everyone else what to do, they just don't make people feel safe. And so what this is also saying is that this could decrease patient safety, probably also some certain patient outcomes, and potentially increase clinician turnover as well. Because what you're going to have, and Bree did a thing on parallel process, is that if you have hierarchical control and organizational control from the top, that parallel process is also happening between the clinician and their patient. So, so if they're saying, if you're going to have a more democratic style approach to giving care, you probably are going to want to also have that mirrored in the way that you take care of your employees, thereby reducing clinician turnover. That's my interpretation. Is that fair, Bree?
Yeah, I really think that is a really fair interpretation of you need people at each level to have that sense of safety, to be able to have that democratic process, to be able to ask questions, to bring up concerns. And if that's lacking from the top
Yeah.
down, that there often isn't going to be that space for those things to happen within that kind of client provider relationship as well.
Yeah, absolutely. Um, and so to wrap up, let's see, our study emphasizes the importance of the interpersonal aspects of a safety climate in enhancing patient and clinical outcomes in healthcare. And so this does really confirm, work that we've done here at 10 Collective as consultants. I worked with nursing students in one consulting program that we've done, and just learned that interpersonal communication is not something that's part of the curriculum necessarily when it comes to being a clinician. And this can often be one of the most impactful ways to make a difference in someone's life, is to really enhance your ability to communicate. What I was hearing from nursing students was like, these are really hard conversations to have. These are really personal issues. Different healthcare concerns can be really sensitive, really personal. They could potentially be life or death. And yet clinicians are not necessarily trained on how to talk about these things in a way that makes everyone feel safe. And so there is a real opportunity here to offer what we've traditionally called soft skills, which of course I hate, because it really should be the core, the foundational skills of how we relate to each other, and how we can make people feel safe or unsafe based on how we are able to communicate with them. So, hey, bring on 10 Collective. We will help you with this. We can help your healthcare setting with all of these things. This is what we were founded to do. So that's it for today. Wow, that was some good ones. And so we will see you again next week, same day, same time, to go over the trauma-informed care positive and adverse childhood experiences and psychological safety news. If you see anything you want us to cover, send it our way. And we so appreciate you joining us here.
Thanks for tuning in.